Hi, everyone, and welcome to a segment today called Radiating Health, Insights from a Breast Imaging Expert here at Chesapeake Medical Imaging. Joining me is Dr. Eva Duckett, who has over 30 years of breast imaging experience, a significant amount of research contribution, and has participated in about 50 other lectures and features surrounding this important topic of breast imaging. Welcome, Dr. Duckett.
Well, thank you for having me. It's a pleasure to be here.
Dr. Duckett, before we dive straight into some breast imaging questions, you're returning to CMI, where you had spent 10 years from 2009 to 2019 and rejoined us at the beginning of this year. In your return to CMI, what has stayed the same? And then what has changed or evolved in the past 5 years? I know one thing that's changed is we have two brand new Hologic machines at Defense Highway and Bowie.
Absolutely. So I think what has stayed the same is the commitment that CMI has to the patients. It's a very patient-focused, patient-centered operation, and that's one of the things I always loved and the thing that drew me back. And I think as far as what has evolved in the past 5 years is our understanding of how important breast imaging really is. And we are investing in that now, and we have these brand new machines that are, and some new technology also, some new biopsy technology also at our Annapolis office called the Brevera breast biopsy device. It's a stereotactic biopsy, and that's brand new. And our brand new 3D Genius Hologic machines that we're already getting a lot of compliments on from the patients, and just really appreciating how important breast imaging and breast health is and our new commitment to that.
Dr. Duckett, I love how you have highlighted kind of the patient-focused care that CMI provides. It's such a pillar to the foundation here. And you're right, the investment in breast imaging, really exciting. You spend your days peering into mammograms, ultrasounds, and MRIs. But what sparked your interest in breast imaging?
So one thing I wanted to mention is that breast cancer affects about 1 in 8 women. And that's a lot of women, which means that this disease actually affects us all. We all know someone, and I'm not any different. I have this disease in my family, an aunt on each side. And breast imaging happened to be the very first rotation that I did as a radiology resident, and I just embraced it. It became kind of a focus of my training, whereas by the end of my training, I was doing a lot of the breast imaging for the radiology department on my own. So it was kind of a love at first sight thing. And I saw how it could impact a woman's health and how much we were actually helping people, not only with their cancer diagnosis or getting them through their treatment, but also just in general, their health, and especially with their breast health.
Dr. Duckett, you mentioned kind of breast health, and I know you're a breast specialist. What does it mean to be a fellowship-trained breast imager?
So after you finish medical school, you usually go to an internship for a year, and radiology residency follows, and that's about a 4-year stint as a radiology resident. Then you've completed your training. You are a radiologist. You take your boards, you pass your boards, and then if you want to go into subspecialty training in any particular area, let's say pediatric radiology or neuroradiology, you would do what's called a fellowship. So a fellowship is additional training on top of the basic training. So breast imaging fellowship after radiology residency, that's what that means, that it's an exact focus on that specialty for a year or 2 years, depending on what subspecialty you're trying to do.
That's fascinating. All that education goes into being a breast specialist. And Dr. Duckett, you know, we all hear about mammograms, and kind of give us a sneak peek, like what goes on behind the scenes in a radiologist world? Can you walk us through your typical day and the different technologies that you use?
Absolutely. So the mammogram is our gold standard. So women over 40 should come get their mammogram every single year. Now, about 1 in 10 women will be called back. Now, I know this causes a lot of anxiety for women when they get called back, but the callback is because there's something there we just need to clarify, because when we say goodbye to you after your mammogram, it's for a whole year. We need to make sure that you're clear. Now, 80% of the women that we call back are going to be clear, so don't worry if you get called back. But when you get called back, you may need additional imaging, such as additional mammogram pictures that are specialized views. We call that diagnostic imaging. Or you may need a sonogram or even a breast MRI to help us figure it all out. So I usually tell my patients, don't worry till I tell you to worry, because a callback is very common, and that's something that happens to a lot of women. It doesn't mean that there's necessarily anything wrong. My typical day, I'm reading mammograms all day long, and they can be the regular screening mammograms of women who have no symptoms, or it can be a diagnostic mammogram of a woman who has a problem that we're trying to figure out or investigate. We also do biopsies, cyst drainages, read the breast MRIs as well. So that is all encompassing for breast imaging. It's not just the mammogram.
And Dr. Duckett, I know many listeners might feel anxious about screenings, and we had the pandemic and COVID, and some patients maybe said, you know what, I'll skip this year, which turned into 2 years. And can you shed some light on the role of a radiologist in early detection, and what happens after you might see something in an image?
So when we see something or a patient is having a symptom, we do those callback images, and I'm usually very honest with the patient about my level of worry, but we would work that abnormality up based on the imaging or based on her symptoms. So breast cancer can appear in so many different ways. It can be just a little erosion of the nipple or an inversion of the nipple or a dent in the skin. It can be a lump that you feel. It can be a discharge from the nipple. It can be a lump under your arm even. So just keeping those things in mind, there are many different ways it can present. Clinically, it can also present in many different ways on the images. It can just be a little blush of increased density. It can be calcium deposits. It can be an actual mass or tumor that we see. So my role is to find that cancer and to find it as early as we can, because the earlier that we find it, the better your outcome will be, and then the less treatment you may need to get rid of it. So the early detection really does save lives. I want to really drive that point home. That is the whole point, is to find it as early as we possibly can before it has a chance to develop or grow or spread. Breast cancer is what I call a stealth cancer. It likes to fly below the radar as long as it can. It wants to grow, spread, and do all the bad things. So when you do your breast exam, and I know you didn't ask me this, Tom, but I'm going to add this in. When you do your breast exam, a lot of women tell me, I don't do that breast exam because I'm lumpy anyway. I'm a lumpy person. Well, most lumps are your good lumps, and it's actually the lumpy tissue and not a lump in your tissue. And those lumps should feel kind of firm and rubbery. You should be able to move them around, and they might be a little sore or tender. That's your good lump, actually. Cancer, on the other hand, it's very hard, like a little rock or pebble, and it's stuck. It's actually fixed to the tissue, and it does not move when you try to push it, and it usually doesn't give you any pain. That hard, non-hurting, non-moving lump is the one I really want you to pay attention to. It doesn't mean it's cancer, but I need you to come right in and get that checked out. So I just wanted to go over that quick difference in lumps and good lumps versus bad lumps, because you, if you are a lumpy person, are the person that might find the lump that's different from all the other lumps, as opposed to your doctor. So do call that to your doctor's attention, but do come get it checked out. Even though it's not hurting, that is actually a key thing that I need you to come get checked out.
Dr. Duckett, you mentioned early detection is key, right? But there's a lot of information out there, and some of it's inaccurate. What are some common myths or misconceptions you encounter about breast screenings and self-examinations?
Well, some of the myths, some are actually a little bit true. Like, does it hurt? Sometimes the mammogram does hurt because we actually are squeezing your breast tissue in that machine. But we ask women to please come the week after your cycle is done if you're still cycling. And maybe you could take a Tylenol and you'll be able to take that compression better, because the more that we can compress and smooth that tissue out, the better the image will be for me, and the easier the cancer would be to detect if it's there. So that's not really a myth, but I do want you to come and just take that compression just for those few minutes. And most women tolerate it very, very well. So it's a good screening test for that reason. A lot of patients tell me another myth is that it's too much radiation. It's actually much less radiation than the mammograms we used to do back in the 80s and early 90s. These digital mammograms that we are doing now are very minimal radiation. I often even stand in the room with the patient when they're getting the mammogram. I have a couple patients that tend to pass out sometimes, so I stand in there with them. So it's really very minimal radiation. You may get more radiation have a short airplane flight than the mammogram itself. It's actually the benefit far outweighs the risk of the minimal radiation that you're getting for your mammogram. Another one I hear a lot as far as myths is that, well, I don't have this in my family, so I don't need to get this mammogram and I don't need to get it every year. Well, it's those very subtle changes from year to year that we're looking for. And please keep in mind that those genetic things that you're hearing about in the media is only about 5% of the women that are diagnosed with breast cancer. The large majority of the women that we diagnose have no reason to be considered high risk, no reason for me to think that they should get breast cancer. So you tell me you don't have it in your family, I'm saying, great, you're the perfect person to get it. So I don't want you to ever think that just because you don't have it in your family means you're not going to get it, because it does have to start somewhere. Keep that in mind.
And Dr. Duckett, I know starting baseline screening mammograms, there's a different ages out there. There was a task force years ago that recommended starting at 45. And if you're good there, then come back at 50 years old. Kind of what's your guidelines here and our guidelines at Chesapeake Medical Imaging? When should you start? And if you have a family history, how does that change?
So screening mammography should begin at age 40 and every year thereafter. And that is not only from the American College of Radiology, but also the American Board of Surgeons, Society of Breast Imaging. So all of our major organizations recommend annual screening beginning at age 40. Now that is for a woman at average risk. Now, a woman who may be high risk because of her family history, and keep in mind, family history, the main relatives that bump up your risk would be your mother, your sister, or your daughter. Those are your first degree relatives. Grandmothers, aunts, cousins, they count too, but they do not increase your risk as significantly as those first degree relatives. So if you have a first degree relative, you may be considered high risk, and you may even consider undergoing some genetic testing just to make sure. But whether you actually test negative for a genetic mutation or positive for a genetic mutation, you are still high risk because of that first degree relative that was affected. So let's say your mother was diagnosed at 45, then I would subtract 10 years from her age and start you at 35 and every year thereafter instead of the 40. So that is where the starting a little earlier might come into play, and where adding a breast MRI as part of your imaging surveillance might also come into play.
Thank you for clarifying that, because I know a lot of different numbers being thrown out there on when to start in family history. So thank you for clearing that up. Dr. Duckett, CMI now has 12 locations. Where are you hanging your hat these days, and where can we find you?
Well, I'm primarily at the Annapolis location on Defense Highway. I am usually there 3 days a week, and then I am at the Bowie location as well, usually on Wednesdays. So please come see me there.
And I know, kind of going back to some of the misconceptions, Dr. Duckett, with the technology that we have these days, if you're in Defense Highway, you can read scans from Bowie or Annapolis or Towson or wherever. That's correct?
Absolutely. So our computers and our PACS systems have taken over the world. We can actually read your study from anywhere.
Wonderful. Dr. Duckett, let's get to know you a little bit. Behind the technical side, what would you say is the most rewarding aspect of your work?
Well, I'd say the most fulfilling aspect is just helping women to understand their breast health and helping them through the journey of breast cancer. One thing a lot of people don't realize is the journey, once you're diagnosed, is actually about a year long. So it is my pleasure to help these women through that process, but also to answer any questions they may have just in general about their breast health and their overall health too, as far as women being their own advocates and really paying attention to their health, because we help everybody else. We take care of everybody, and sometimes we neglect ourselves. So I need to make sure that women are taking care of themselves. And I do want to just put that out there. Please do not skip your mammogram from year to year. I know life takes over sometimes and you're very busy, but please take that moment for yourself to come and get your mammogram every year.
Dr. Duckett, I know that you have shared that you've been impacted by cancer, and I'll share that my grandmother was impacted for cancer, and you mentioned journey, and unfortunately we were able to see that journey firsthand for 14 years, and it's great to hear that you are tuned into that. You are tuned in it from a patient's perspective and really want to be along their side and be part of that journey. So Thank you for sharing that. And on a lighter note, when you take off your radiologist hat, what do you enjoy doing for fun?
So for fun, I do a lot of walking. I like to do all the charity 5Ks that I can, and I do jigsaw puzzles. I love putting together and solving problems in different ways. And that's jigsaw puzzles gives me that. It's sort of a metaphor for life in some very, very interesting ways. I love spending time with my family and friends. I've been married for 33 years, almost 34 years now. I have two grown adult sons. One is 27 and the other is 23, so I enjoy spending time with them. And I have one brother too, and I hang out with him a bit, so I just really like hanging out with family and friends.
Dr. Duckett, thank you so much for sharing your expertise and sharing a little bit into your personal life.
Thank you. Thanks for having me.
Sure thing. And that's all for today, everyone. And remember, knowledge is power when it comes to your health. Don't hesitate to talk to your doctor about any concerns and schedule regular screenings as recommended. Dr. Duckett is on site at both our Bowie and Defense Highway locations. And we also have Dr. Allison Williams, who is another breast specialist who is on the Eastern Shore at our Easton location. Until next time, stay healthy and informed.